Hello, Klimik Review family. It's Dr. Sharon with Klimik Reviews. Today we're talking about hypovolemic shock. You know, in many ways, shock is shock is shock. Most of the shocks have the same problems, primarily impaired tissue perfusion. But today we're going to talk about shock when there's a low volume. So let's go ahead and get started with that. Hello, Klimik Review family. It's Dr. Sharon with Klimik Reviews. You know, we're part of the greater Klimik Review organization that focuses on NCLEX review by Mark Klimik himself, who started Klimik Reviews 40 plus years ago. And, you know, I've known Mark for a long time, and he is truly the greatest teacher I've ever met. Everything I've learned about teaching, I learned from him. He has the ability to see patterns where other people can't see patterns. And the reason he's such a phenomenal teacher is because he shows us the patterns, and then things all of a sudden become logical. We go, oh, that's why that works. Okay, I get it now. And so he brings that gift to his NCLEX review, which is why it's been so popular and remains to this day to be so popular. You can get it online on demand from klimicreviews.com. It's taught by Mark himself. You get the yellow book with that. It comes in multiple different small short lectures that you can watch, and you can purchase it for a number of months that you want to get it for. So I recommend doing that if you're getting ready to take your NCLEX, especially if you're getting ready to take it for the second, third, fourth, fifth, sixth, seventh, or eighth time. I know people who've passed NCLEX after failing it multiple times. You can absolutely pass. And I know Mark Klimik can help you with his NCLEX review. So let's go ahead and get started with hypovolemic shock. The last video that I did, if you're watching this when it just comes out, the last video that I did was on blood pressure. So these two go together, which is why I'm sort of publishing them here together. And this one is specific to hypovolemic shock. So we're going to talk about, just really super quickly what I talked about blood pressure in the last one. So blood pressure equals cardiac output times systemic vascular resistance, which means blood pressure equals heart rate times stroke volume times systemic vascular resistance. So if we're talking about hypovolemic shock, shock is a drop in blood pressure, which results in decreased tissue perfusion. So when I'm perfusing my tissues adequately, my brain is functioning fine because I'm perfusing my brain. My lungs are working fine because I'm able to get air into them. My heart is working fine because I'm able to get oxygen to the tissues. My kidneys are working fine because I'm able to make urine. My gut is working fine because I'm able to have peristalsis. I have positive bowel sounds. My skin is perfused. It's nice and pink. I have good pulses peripherally, right? So all of these things tell me they have good tissue perfusion. The blood pressure, when you have shock, the blood pressure drops enough that you have impaired tissue perfusion. And blood pressure is affected by heart rate, stroke volume, and vascular resistance. Therefore, as the blood pressure drops enough, the area, and they start to have poor tissue perfusion, the only ways that we can intervene are by increasing heart rate, increasing stroke volume, or by increasing systemic vascular resistance. And hypovolemic means low volume. So volume changes affect primarily stroke volume. And when stroke volume starts to go down, right, overall volume goes down, it affects systemic vascular resistance to some degree. But the SVR can be compensated for through vasoconstriction, which is why they get real pale. One of the reasons they get real pale is because the body vasoconstricts the non-important organs, and skin is one of the least important organs. So it wants to make sure it's perfusing the heart and the brain. And so the body starts to vasoconstrict, so you get less perfusion to the kidneys and so forth, and to the gut and to the skin to maintain tissue perfusion to the heart, the lungs, and the brain. And so that's through vasoconstriction. And so although low volume does affect SVR in the long run, initially it affects stroke volume. So when stroke volume, the amount of volume that's ejected by the heart with each contraction, when volume goes down, the body tries to compensate. Yes, it does vasoconstrict, but first it increases heart rate. So heart rate is the first symptom that someone's starting to develop a shock. The only exception to that is neurogenic shock. I'm not talking about neurogenic shock, but every type of shock, the earliest symptom is tachycardia, with the exception of neurogenic shock. And so these hypovolemia essentially changes stroke volume. What can cause hypovolemia? trauma and blood loss. So they get into a car accident, they get stabbed, they get shot, something happens. Surgical blood loss can lead to hypovolemic shock. GI bleed, blood loss. So if you get a patient who's admitted with a GI bleed, y'all, you better be watching their heart rate, their blood pressure, their level of consciousness. Look for pallor in their skin. Look for decreasing urine output. Dehydration. Lots of older adults get dehydrated. Either they become dehydrated through hyperglycemia. So you can see I put DKA and HHNK there. Diabetic ketoacidosis, which results in polyuria, increased urination. HHNK, hyperosmolar hyperglycemic non-ketotic coma, results in increasing urination as well before you end up in the coma, and then also sustained vomiting and diarrhea. So these are some risk factors. So if you get a question on the NCLEX or you admit a patient with any of these problems, y'all, you need to say this person is at risk to go into shock, and I need to monitor their vital signs. These are called vital signs for a reason. Heart rate, particularly blood pressure. When you hear the word hemodynamic, hemo, blood, okay, hemodynamic. How can we monitor non-invasively the hemodynamics of the patient? Blood pressure and heart rate, y'all. That's how we measure it, blood pressure and heart rate. So when you hear that someone is hemodynamically unstable, that means their blood pressure is dropping or their heart rate is going through the roof or their heart rate is dropping, one or the other. And so you have to think stability for the patients. And one of the things NCLEX really wants to know is that you can identify an unstable patient. You don't always have to know what to do in the big everything. You don't have to know everything to do for an unstable patient, but you should be able to identify how to at least start to stabilize this patient. And so if they give you a patient who is hemodynamically unstable, in other words, their heart rate is super high, their blood pressure is super low, you have to be able to say, what would I do for this? And if you know blood pressure equals heart rate times stroke volume times vascular resistance, let me go back to that. You know that if blood pressure starts to drop, we can either increase heart rate, we can increase volume, stroke volume, or we can increase vascular resistance. Well, the body already is stimulating the heart rate to go up. Okay, the sympathetic nervous system is always already saying, "Hey, increase that heart rate." So we got a dropping blood pressure. We already have an increasing heart rate. So the easiest thing for us to do is increase volume. That's why we give saline boluses for people whose blood pressures are dropping. That's the easiest way that we can increase it. Now, hypovolemic, does that mean they're bleeding out? It might, but don't assume it does. Don't assume you have to give blood unless they give you some indication that they need to have a transfusion, okay? If they tell you, and generally we don't transfuse until the hemoglobin is under 8. So if they tell you the hemoglobin is under 8, then our priority is going to give blood. But if they don't tell you what the hemoglobin is, or they tell you the hemoglobin's 10, we're not going to give blood yet. We can give fluids. We can give crystalloids. Crystalloids are crystal clear fluids. And typically the isotonic fluid that we give is normal saline. But don't give blood unless they tell you that the hemoglobin is under 8. All right, let's do some questions. A nurse is caring for a client who's at risk for hypovolemic shock due to excessive vomiting and diarrhea. So we know that's a risk, right? They're losing lots of fluids. They can be hypovolemic. Which of the following findings should the nurse expect if the client is developing hypovolemic shock? All right, let's see. Bradycardia and hypertension. Well, hopefully not. Hopefully you know that's not right, okay? Decreased respiratory rate and hyperthermia. No. Bounding pulse and peripheral edema. No. Bounding pulse and peripheral edema is fluid volume overload, y'all, not hypovolemia. Tachycardia, yes. Remember, the earliest symptom is tachycardia, and narrowing pulse pressure. Okay, if you watched my blood pressure video, you know what a narrowed pulse pressure is. A narrowed pulse pressure is when the systolic drops and the diastolic either remains the same or goes up. Okay, it could remain the same. What happens? So a pulse pressure is the numbers between the top and the bottom, systolic and diastolic. So the pulse pressure of 120 over 60 is 60, because 120 minus 60 is 60. So the pulse pressure for a blood pressure of 120 over 60 is 60. The pulse pressure for a blood pressure of 110 over 70 is 40. Because that's the difference between those two numbers. The pulse pressure for a blood pressure of 100 over 80 is 20. Do you see how that's getting narrower and narrower and narrower? You could also see the diastolic staying the same. So if you start at 120/60 and they're losing blood, you're going to start to see, you may see that systolic dropping and the diastolic staying the same. So you may see going from 120 to 110 to 100 to 90, and the diastolic may be staying the same. Why is the diastolic staying the same? Well, it's staying the same because it's the body is vasoconstricting, but because the volume, they're losing all this volume, they're able to maintain a diastolic pressure, but they can't make it go up because the volume keeps going down. So they're vasoconstricting at the same time that they're losing volume, and they're able to somewhat manage mean arterial pressure, but the pulse pressure really starts to narrow. The nurse is assessing a client who has sustained multiple injuries in a motor vehicle accident. Which of the following findings indicates the client is experiencing early hypovolemic shock? Decreased urine output, increased blood pressure, warm flush skin, or bradycardia? So I was looking for tachycardia, but it's not there. So I'm not going to pick bradycardia. I'm certainly not going to pick warm flush skin, because that means they're getting more blood flow to the skin. And I don't like that, because the body's first response is to vasoconstrict the non-important organs, and you have impaired tissue perfusion there. So that's not good. And I know shock is not increased blood pressure. So could decreased urine output be an early symptom? It could be, because it's trying, the body is trying to divert blood to the most important organs, like the heart, the lungs, and the brain. So it's diverting blood away from the kidneys, and urine output goes down. It doesn't say that the urine output is 0. Okay, that's not what it says. It just says it goes down. And that makes sense, because it's trying to retain fluid, and it's also diverting blood flow away from the kidney. So that is an early sign. Now, by the time you get into full-blown shock, you're going to have 0 urine output, y'all. The body's going to be not letting any of that fluid go at all. Client is admitted with gastrointestinal bleeding. Which of the following interventions should the nurse implement first? Okay, GI bleeding. So I am worried about shock. I'm worried about blood loss. So let's see what we've got. Start an IV line with a large bore catheter. Absolutely. Absolutely. Prepare the client for endoscopy. Yeah, absolutely. Obtain vital signs. Absolutely. Administer prescribed proton pump inhibitor. I want to do that, but that doesn't seem like the first thing I would want to do. So if I have to do all these things, I don't know actually what their vital signs are. And since I don't know what their vital signs are, y'all, I got to do that first. I have to. The second thing I would do is to start the IV. And the third thing I would do is prepare them for endoscopy. And then I would give them their proton pump inhibitor. So I would definitely, I have to know what their blood pressure is. Okay. I have to. I don't know how to explain that other than to just say vital signs are called vital signs for a reason. We have to know if they are hemodynamically stable or not. That's going to motivate, or it's going to guide my actions for the rest of my time. So I have to determine their stability. The nurse is caring for a client with hypovolemic shock due to severe dehydration. Which laboratory value would the nurse expect to find? So we have a low volume. Okay, low volume, elevated hematocrit, decreased serum sodium, decreased blood urea nitrogen, or increased prothrombin time. Okay, prothrombin time has nothing to do with it. Okay, so that has nothing to do with it. And we have to remember this is severe dehydration, not blood loss, not blood loss. So when you think dehydration, you have to think hemoconcentration. So you haven't lost any red blood cells or hemoglobin or hematocrit. You've just lost the plasma. You've essentially just lost plasma volume. So everything is going to be super concentrated. It's not going to be diluted, because if someone becomes volume overloaded, a lot of times their hemoglobin and hematocrit drop, not because they're bleeding, but because it becomes diluted. The blood becomes diluted with increased serum, right? So and that's the same with BUN. So BUN goes up when they are concentrated. The same amount of waste product in the blood, but because there's less serum to dilute it, it becomes concentrated. So these are some things to think about. Remember, they're not losing blood. So I actually would expect the hematocrit to go up, just like I'd expect the hemoglobin to go up, just like I'd expect the red blood cells to go up. I'd expect the BUN to go up. Okay. I'd expect the sodium to go up. The potassium might even go up a little bit. I don't know how much it would go up, but it would certainly go up a little bit. because of concentration. Everything's so concentrated. So we're not going to pick B or C. D has nothing to do with it. So the correct answer is elevated hematocrit. A client is receiving blood transfusions after experiencing hypovolemic shock from a traumatic injury. Which of the following findings indicates a transfusion reaction? Select all that apply. So you do need to know transfusion reaction for NCLEX and for real life, y'all. You got to know it. It's a very common problem. All right. So how do we know they're having an allergic reaction? That's what it is. A transfusion reaction is an allergic reaction. Low back pain. That is allergic reaction. So yes, hyperthermia. The temp goes up. Yes, that's an allergic reaction. Hyperreflexia. Reflexes really don't have anything to do with it. Urticaria. If you don't know what the word urticaria means, it's a rash, and a rash is an allergic reaction. Hypoactive bowel sounds. No, that doesn't have anything to do with an allergic reaction. So low back pain, hyperthermia, and urticaria are your symptoms of transfusion reaction. You can also listen for wheezing, narrowed airway. You might have a lowering. If it gets really bad, you could have a lowered blood pressure and tachycardia, but that would be if they're going into an anaphylactic shock. So really what I'm most concerned about are some of these early symptoms. Low back pain, temperature goes up. It doesn't have to go up a lot. It can go up a couple points, a rash, or wheezing. Which of the following clients is at highest risk for developing hypovolemic shock? Client with a history of hypertension. Okay, that's not, we talked about risk factors, right? That's not a risk factor. Client with severe burns covering 40% of the body. Y'all, they lose a lot of fluid through burns. When they burn the skin, it's what is holding all the fluid in our body? Well, the skin is helping to hold a lot of it in, as well as the capillaries. So when you damage those capillary walls in the skin with burns, you lose a lot of fluid. And 40% of the body, y'all, that's enough that they may not survive that. That's serious loss of fluid. A client with a urinary tract infection, that's not a risk factor. That's a risk factor for septic shock if they become septic, but not hypovolemic shock. A client scheduled for a colonoscopy, that's not a risk factor. So burns is a serious risk for hypovolemic shock. A nurse is administering IV fluids to a client in hypovolemic shock. Which of the following assessments best indicates the effectiveness of the therapy? So giving IV fluids to try to increase tissue perfusion. Yes, I want their blood pressure to go up. Yes, I want their heart rate to go down, but I'm primarily trying to increase tissue perfusion. So we want to pick an answer that shows they're having better tissue perfusion, okay? Decrease in heart rate. Well, that's good. I'm glad they have a decrease in heart rate. That's good, but it doesn't really tell me they have increased perfusion. Increase in respiratory rate. That doesn't really tell me anything about perfusion. Decrease in body temperature. That doesn't tell me anything about perfusion. Increase in urine output. Y'all, there you go. Increase in urine output tells me if they're perfusing their kidneys, the body is no longer having to shunt blood away from the kidneys to hold on to it, right? They're not vasoconstricted anymore. They're not keeping all the blood to, our body's not holding on to everything it can. So when I see an increase in urine output, that is the best indicator that they are reperfusing. A client in hypovolemic shock is prescribed a norepinephrine infusion. What is the primary goal of administering this medication? All right, norepinephrine is one of the neurotransmitters found in the sympathetic nervous system. The sympathetic nervous system is that fight or flight nervous system. Norepinephrine, what it does specifically when we give it is it vasoconstricts. Remember, blood pressure equals heart rate times stroke volume times SVR, systemic vascular resistance. Vasoconstriction increases systemic vascular resistance, which increases blood pressure. It's called a vasopressor. Another name for norepinephrine is Levofed. One of the other names for it is Levofed. It's a vasopressor. When you hear the patient's on pressors, this is one of the pressors they're probably on, okay? Now, we have to be super careful with pressors because when we vasoconstrict, just like when the body vasoconstricts, it's pulling blood to the vital organs. It's vasoconstricting all those non-important organs, right, to maintain blood pressure. If they're on vasopressors for too long, y'all, they can start to necrose their ears, necrose their nose, necrose their fingers, necrose their toes, because we're shunting blood away from the non-vital places, and they can actually start to necrose those places. So you have to be very careful with vasopressors. However, What is the primary goal of administering this medication? Vasoconstriction, yes. Increase heart rate, no. Reduce cardiac workload, no, absolutely not. It doesn't. Vasoconstriction does not reduce cardiac workload. Promote diuresis, no. That's not its primary goal, because we're trying to hold on to fluid, not get rid of it. A client in hypovolemic shock requires rapid fluid replacement. Which IV solution should the nurse anticipate administering? I say on the NCLEX, almost always the right answer is 0.9 normal saline. It's almost always the right answer, except with burns. We use LR, lactated ringers, with burns. Other than that, we use 0.9 normal saline. These LR and 0.9 normal saline are isotonic solutions, which means they get the same tonicity, the same concentration of stuff as our blood. So it doesn't cause all these major shifts of fluid from in and out of the cell and out of the capillary bed and all that. So that's why 0.9 and LR are the best, and 0.9 is the most common answer on the NCLEX. Never bolus with dextrose solutions, because once that dextrose is going to be used up for energy, right? Dextrose is going to be metabolized, and all that's going to be left is either the water or the 0.45, which are not isotonic solutions and can cause problems. And then 0.45 is not an isotonic solution. Nurse is caring for a client in hypovolemic shock who's receiving a blood transfusion. The client reports chills and a headache 15 minutes into the transfusion. What is a priority nursing action? So what do you think is going on? Why do we monitor vital signs? Why do we stay in the room for the patient with the patient for 15 minutes after we start the blood transfusion? Why do we do that? To see if they have an anaphylactic reaction, an allergic reaction. What do we do if they have evidence of an allergic reaction? We stop the transfusion. First thing, stop the transfusion and go, I got to call the doctor. No, you're not. That's not what you're going to do. You're going to stop the transfusion. Then you're going to call the doctor. Okay. Then you're going to call the doctor. You're going to send the bag down to the lab for evaluation. You're going to send off a urine specimen so they can evaluate to see what's going on. You're going to set down some blood work to see what's going on. And there may be one other thing that you have to do, but you have to call the doc, stop the transfusion, send the blood down to the lab, send the urine down to the lab, and blood specimens down to the lab. I think that's all you have to do, unless they give you orders, to give something. In planning care for a client at risk for hypovolemic shock, which of the following interventions should the nurse include to detect early signs of shock? Which is you always want to detect it early, right? Because you don't want them to go into full-blown irreversible shock. And I didn't even notice. Okay, monitor bowel sounds every 8 hours. Well, that's okay, but you're only doing it every 8 hours. It's not really going to, they could go into shock between those two assessments. That doesn't seem like a good idea. Measure intake and output every shift. Well, every shift is every 8 hours or every 12 hours, depending on the type of shift they do. And if I'm going to watch for decreased urine output, I'd like to do it more often than every 8 hours. So that doesn't seem like I'm going to catch it early. Assess vital signs every 15 minutes. Well, now I'm going to catch it early if I'm doing 15 minutes. Check level of consciousness every hour. Honestly, the vital signs are going to change. The heart rate's going to change before I see a change in level of consciousness. So I need to do the vital signs every 15 minutes. A client with hypovolemic shock is being treated with IV fluids and vasopressors. And you know what vasopressors are now. The nurse notes that the client's CVP, central venous pressure, has increased from 2 to 8 millimeters of mercury. How should the nurse interpret this finding? So someone who's hypovolemic has lost volume throughout their whole body. So not only does their mean arterial pressure drop, but their central venous pressure drops. If you remember from my blood pressure lecture, blood travels from areas of high pressure to low pressure. So when you lose overall volume, both your arterial and your venous side drop in pressure. Normal venous pressure is somewhere around 10, I usually say. That may not be the exact number, but somewhere around 10 millimeters of mercury. And so it's increased, right, from 2 to 8. So how do I interpret this? The client's experiencing fluid volume overload. No, if they're experiencing fluid volume overload, you'd see a CVP of like 22. Okay, 22. That's volume overload. The client's fluid status is improving. It certainly is, because I expect it to go up as I'm giving him volume. So yeah, and by going up, that means the pressure is going up. The client is developing cardiogenic shock. No. Cardiogenic shock, I'd see, again, fluid volume overload with CVPs of like 22. The client requires additional fluids. Well, not yet. I mean, we may need to eventually, but not yet. It's definitely improving. So the client's fluid volume status is improving. The nurse is caring for a client with hypovolemic shock due to hemorrhage. Which of the following blood products should the nurse anticipate administering first? All right, hemorrhage. So when we give blood, we almost never give whole blood. Whole blood is everything. We almost always give packed red blood cells. Packed red blood cells is they've pulled the serum out of there, and they're giving just concentrated packed red blood cells, which is what we give when someone has hemorrhage. Now, we also are giving IV fluids, right? We're also giving 0.9 normal saline, but we're giving the packed red blood cells so that we can get those red blood cells in them much more quickly. And so fresh frozen plasma is that plasma that we've separated out from the red blood cells. We do at times give fresh frozen plasma. That's given for a totally different reason, like bleeding problems. And what I mean by that is their PTINR is high. They've overdosed on Coumadin, warfarin. We can give them fresh frozen plasma, okay, to help with the bleeding times, not the actual hemorrhage. We give packed red blood cells when they're actually hemorrhaging. Platelets are given for low platelets. Albumin is given for third spacing. Edema, third spacing. We may need to give it, but certainly not yet. We need to give packed red blood cells. So that's what we're going to give them. I can't say we never give whole blood. I've just never given whole blood. I don't know why we would give whole blood. I don't know what the scenario is for that. So if you know, you can put something in the comments. Client with a GI bleed is pale, diaphoretic, and has a heart rate of 130 and a BP of 90/60. All right. So what I say to myself is they're diagnosed with a GI bleed and they're showing signs and symptoms of shock, going into shock. Their blood pressure is not quite low enough to say they're full-blown shock, but they're definitely going into shock. The nurse receives the following orders. What should the nurse implement first? Prepare the client for emergency endoscopy, establish IV access and begin administering isotonic fluids, obtain a stat, hemoglobin, and hematocrit, serum type, and screen. We need to do all these. Serum type and screen means get their blood type. So if we need to give them blood, we can give them blood, because we're not going to know if we need to give them blood until we've gotten stat, hemoglobin, and hematocrit. All right. So when you read this question, and I know it says stat, hemoglobin, and hematocrit, you can't let that throw you off. Okay. When you get a question like this, you've gotten a diagnosis, GI bleed, and you've gotten symptoms in the question. Here, what are the symptoms? Pale, diaphoretic, tachycardic, low blood pressure. These are actually all objective physiological findings. They're objective physiological findings. When we prioritize what to intervene with, we always prioritize objective physiological findings, followed by safety issues like suicidal ideation, followed by subjective findings like I feel bad, I'm having pain, subjective, this is how I feel, followed by psych issues. And then some other things, but those are like the top four. So I have to intervene first. I have to address the tachycardia and low blood pressure. Now, they don't give me an O2 sat. If they gave me an O2 sat, what I would say to you is I would say when you have two physiological objective findings and you don't know which one to intervene with first, use ABCs. This is the only time you can use ABCs, when you have two objective physiological findings. And ABCs is airway, breathing, circulation. Well, I don't have airway, breathing here. That's not an option. All I have is circulation, heart rate, blood pressure, and they're pale and diaphoretic, right? Which are also objective findings. So I have to address the circulation issue. Which of these orders addresses the circulation issue? The only one that addresses the circulation issue is giving fluids. I have to do that first. What would I do second? I don't know. I don't know. It doesn't matter what I would do second, because that's not what they're asking. They're only asking, what would you do first? And you're going to get questions like this. You're going to get questions where they give you the diagnosis in the question, followed by assessment findings. They could be objective findings. They could be subjective findings. And then they say, which order do you want to implement first? You always implement the order that addresses the objective physiological finding first. Y'all, I'm just telling you, on the test, that is a testing strategy that will work for you when you get questions like this. And if you know what questions, how they write questions, and this is one of the ways they write questions, then you're going to start to see how many times you get questions like this. The question has the diagnosis and symptoms in the question, and then the orders or the interventions or orders are all in the answers. And they say, which one are you going to do first? You go, I don't know. How would I know? I'm telling you how you know right now. So when you do your practice questions, pay attention. You'll see questions like this, and it will definitely help you. During the morning assessment, which client should the nurse see first? All right, y'all, we always see either the unstable, hemodynamically unstable client, or we see the client with a changing assessment or unexpected findings. Those are three things that are going to help you do better on the NCLEX than just about anything else I can tell you. Because the National Council of State Boards of Nursing wants to know if you can identify the unstable client, the client with unexpected findings, or the client who's had a changing assessment, changing for the worse. Okay. And you want to show them that you can do that. So let's look at who we've got to see here. Client with pneumonia requesting a breathing treatment. There's nothing about them that makes them unstable. Don't say, well, pneumonia. No, pneumonia is just a diagnosis. There has to be evidence that they're unstable. But they're requesting a breathing treatment. Yeah, but we don't know their O2 sat. We don't know what their respiratory rate is. Requesting a breathing treatment does not make them unstable. In fact, it's expected that a client with pneumonia would request a breathing treatment. That seems normal to me. A client scheduled for physical therapy. Absolutely nothing unexpected or unstable about that. They're just asking for physical therapy. A client needing assistance with breakfast. Absolutely nothing. I don't even know what their diagnosis is, y'all. They're just hungry. That doesn't make them unstable. A client post-colon resection with a sudden drop in blood pressure. Sudden, that's a changing assessment, y'all, a changing assessment. So who am I going to see first? I'm going to see the client with the changing assessment first, okay? So when they ask you who you're going to see first, you have to pay attention to what the National Council of State Boards of Nursing is going to say, is going to show them that you can clinically reason. Showing them you can clinically reason means I can identify the unstable patient. I can identify the patient who has a changing assessment. I can identify the client who has an unexpected finding. A client is experiencing heavy bleeding from a deep arm laceration. Which action should the nurse take first? All right, what do you think? What do you think they should do without looking at the answers? What do you say to yourself? This is what I have to do. Hopefully you say to yourself, I got to stop the bleeding. Hopefully that's what you said to yourself. And if you, I bet you all said that to yourself, but somebody said, oh, wait, no, I should do something else, because you didn't trust your gut, right? Our gut tells us we got to stop. We all know we're supposed to stop the bleeding. Even if you second guessed yourself, I know that's what you thought first. So we have to look for the answer that shows we know how to stop the bleeding. Apply a tourniquet above the wound. Well, I suppose that would stop the bleeding. But is that how we normally stop bleeding? What is the best way to stop bleeding, y'all? I know you know it. Apply pressure. Isn't that what we always do? Always. Somebody's bleeding, we apply pressure. So I'm like, well, okay, a tourniquet would work, but that's not how we usually do it. Notify the healthcare provider. I mean, yeah, but that doesn't stop the bleeding. What am I going to do? Just let them stay there and bleed out while they call a doctor? Apply direct pressure over the wound. Oh, there's what we always do. We always apply direct pressure over the wound. There you go. Elevate the arm above the heart level. Well, I mean, that might help, but y'all, really? Like, this is common sense. This is straight up common sense. You have to learn how to use your common sense, y'all. I haven't talked about common sense in a while, but those of you who've watched my channel for any length of time know that I have harped on using your common sense, and you have got to use your common sense. Trust your gut. When you get a question like that, and you're like, I didn't study that. Well, you didn't technically study it, but everybody knows how to stop bleeding. Your grandma would get that question right. If you missed it, it's because you were overthinking. Okay. So common sense is going to help you not overthink. So say to yourself, in general, what would I do? In general, because remember, the NCLEX is not testing specific situations. They're testing general principles. Okay. All right. I hope you have a great rest of your week or weekend or whatever it is for you. And I'll see you later. Thanks for being a part of the Klimik Review family.